Without much ado, I would like to start the glaucoma session 1 for the 8th Kasimi Ophthalmology International Conference. And our first speaker is Dr. Sohaib Mustafa. Dr. Sohaib, are you there? Dr. Sohaib? Well, today's session is about potpourri of challenging cases. We all learn from each other's experiences when it comes to dealing with challenging cases. So here we have a huge panel of well-established glaucoma surgeons who practice both adult and pediatric glaucoma, and they were sharing with us their challenging cases. So our first speaker was Dr. Sohaib. Are you there? Yes. Dr. Mohammed Sohaib Mustafa is trained at the
I'm here. Thank you.
At UK, and he's currently a faculty at the American Hospital, Dubai. And we are indeed privileged to have him with us. And he would be presenting a case on an interesting case of myopia. So over to you, Dr. Sohaib.
Thank you very much. Can you all hear me? I'm just going to be sharing my screen. Can you hear me?
Yes, absolutely.
Can you still hear me?
Yes. But cannot
Okay,
see
great.
you.
Thank you very much. So basically, we're going to be presenting great. Thank you. So we'll be presenting a case, quite a complex case of myopia and primary open-angle glaucoma. So no financial disclosures. Essentially, this patient already had advanced glaucoma when he presented to me now a couple of years ago. And he was a high myope with pressures of 32 in the right eye. Left eye was 21, and he's previously had a trabeculectomy with mitomycin C and needling with 5-FU. He was on maximal medication, not so tolerant on acetazolamide. He was on all the topical medications, and his pressures were at the level of 32. So what we had planned essentially is to do a Bervelt tube 250 with a scleral patch graft and the use of fibrin glue, and to put a supramid in situ as well. After all this was done, the right eye pressure was around about 10 on no drops, and the left eye we managed to get down to 14 with some changes in the medications. But you can see that from the field of vision, he has already had quite advanced loss. So how did we go about doing this? Let me just advance my slide here. So I have a video of how we exactly did the surgery. So there are various tubes that we can use, but essentially with any glaucoma surgery, it is good to be in a situation where you are under control of the surgery rather than the surgery be in control of you. And, you know, with all what we have available to us, it was felt that Bervelt was the best option because it gave us the maximum control in terms of bringing the pressure down. Because what we're dealing with here essentially is the high risk of hypotony. And we want to be able to bring the pressure down in a piecemeal fashion, when we want it, in regards to when we look at the healing ability of the person. So what we did here is that we implanted the Bervelt, and you can see here we're doing that 10 millimeters back with 9-proline sutures. We have a supramid in situ. What we did here that was a little bit different is essentially we did 10 nylon ties. So one is on top of the supramid, which was the titer of the stitches. And then we did another one that was proximal to it, which essentially was another safety stitch when we release the one that is above the supramid. So these sutures, which are nylon sutures, we can suturelize them at any point in time. So this gives us good control. And of course, the supramid allows us to prevent any hypotony when we do release these stitches with the laser. So essentially, this is what we did. And we use here we're actually titrating. So what we're doing is we're using a Lewicky infusion about 25, 30 centimeters above the patient's head, which equates to roughly around 14 or 15. So we're seeing what the, with the resistance, how much resistance do we have with the tube? We can advance or detract the supramid. So if we advance the supramid, we get increased resistance. And if we detract the supramid, we get reduced resistance. So essentially, we're able to titrate the amount of flow that we're getting, because we don't want a high pressure in the beginning. We saw the field of vision, so we have very little leeway in terms of pressure control, especially with this intolerance to Diamox. So here we've actually coming to the end of the surgery, we've used fibrin glue in the area of the scleral patch graft and also the conjunctiva. You can see that we have the Lewicky infusion. So these are all the nuts and bolts, or crossing the T's, dotting the I's type of surgical technique that one can use in order to get maximum control out of the surgical procedure and also post-operatively. So what we did essentially was we suturalized the initial stitch around about 2 weeks, and then another one around about 4 to 6 weeks. So we managed to get the pressure down, like I said, in a piecemeal fashion. And the patient has actually ended up with a good result. And over the last couple of years, he's only on one medication at this point. And he's also developed a cataract, which we did extract as well. So he has maintained his field of vision since then. So essentially, the take-home points really are that when we are dealing with these type of complex cases where there is a chance of increased risk of complications or documented complications, we have to actually plan ahead when we're doing the surgical techniques, and also have careful planning post-operatively. So I'd like, thank you very much.
Thank you, Dr. Sohaib. Would you have preferred using a Ahmed glaucoma valve, or is a barreled a valve of your choice?
Yeah, you see, now this is the point. Now we wanted to have, see, if you remember, the pressure was 32. So, and that was on maximal medication. He was taking some acetazolamide, but of course he was intolerant to that. So we are looking for, this is, again, this goes into the planning phase where, you have all of these tubes available to us. We have now the pole tube available to us. At that particular point in time, we didn't have the pole tube, but I guess in hindsight, if I went back to doing such a case now, I would be using a pole tube, which has a little bit more control. The lumen size of the tubing is a little bit less. But essentially, see, Ahmed tube has its role. There's no tube that is out there that is superior to the other. It very much depends on the type of case that you have. So, for example, I do use Ahmed tubes, but I use it mainly for example, cases where I need an immediate pressure reduction. For example, in say rubiotic glaucoma, where the patient cannot really go back and forth, follow up maybe an issue, etc., etc. The problem we have with the Ahmed tube essentially is that we have of course, the hypertensive phase, and then you also have the higher chance of what we call encapsulation. So
yeah, your voice is breaking now. Well, I'm sorry we lost Dr. Sohaib at the point that he was about to make about AGV. But I guess what he really wanted to say was that the chances of a hypertensive phase or an encapsulated bleb are high with an Ahmed valve. So using a non-valve valve is a better way to go, especially it gives you the control that you want to have and have a phasic release of the sutures of the tube, and then, open up the lumen in a phasic manner. So without much ado, we move on to our next speaker, Dr. Ali Al-Sheikh. Dr. Ali Al-Sheikh is a glaucoma specialist with international experience in Germany and Syria, and he's faculty at the Muscat Eye Laser Center, Oman. Over to you, Dr. Sheikh, for your case.
Yeah, thank you, Dr. Barol. I will share my screen. First of all, I want to thank for this kind invitation. Can you see my screen?
Yes, it's visible.
Super. Yeah. First of all, thank you for this kind invitation. My presentation, unexpected causes for AGV complication. No financial interest. This young patient, 26-year-old male, 26-year-old male came to the emergency complaining from pain at the left eye, IOP 20 at this eye, on timolol. Right eye is prosthetic eye. When you see this is here, the picture for this patient is there is congestion. And when I see this picture, I thought this is clear, it's exposure tube. But if you look here, maybe you see this is here, all the AGV moved anteriorly at this, and this is my first expectation. I start an antibiotic and a short steroid, but the patient, for goodness sake, I have a report for my operation from many years. I asked to bring next year. Let's see, this is here the history for this patient. This patient has congenital glaucoma at both eyes in age of 6 months. Right eye had surgery at the age of 6 years, with lost this eye and now on prosthetic eye. The history on the left eye, sclera buckling on April 2012 outside the country. All the other surgery in the same center outside the country. 2 months later, go back to the same center with the recurrent RD and BVR and did vitrectomy with silicone oil. 10 months later, go the same center with silicone oil removal and AGV implantation. Only 3.5 months later, go to the same center with the history of AGV tube extender fixated with fibrin glue, as mentioned in the report. I will start from the end. Why we use a tube extension? Usually, there is 2 indications for the more common complication. This is the retraction of the tube and exposure of the tube. And there is many technique for tube extension. When this is the traditional is from the tube extender from the company, from the same Ahmed Glaucoma valve company. And this is the tube extender. And this is slightly expensive. And there is more another technique. This is less expensive as you to use angiocatheter 22 gauge or a Crowfold tube, or this is trimmed the tube from a second glaucoma drainage device as seen in this video, in courtesy from my dear colleague, Dr. Ahmed Mustafa Abdurrahman. See, this is use this part of the tube and make extension on this fixed on the patent. We test here. He tests the tube and find this is patent on the strong and can use for as a tube extender for as this case. make extension, and can you insert inside the eye. This is the main technique for tube extension. Let me go back to my case. This was my first expectation for the tube movement when I see the patient, but when I see the report, I said maybe this is all both is move anteriorly, or otherwise the AGV blade go posteriorly, and this is the tube extender move anteriorly. For that, I go to the surgery. Let me see what I found. This is here. I start with the surgery. I open. This is not moving. Maybe goes very slowly. Oh. Sorry for this. Now start the tube. See here, I start with the surgery. I open the conch and see this is what I found here. Look here, I open over the tube extender here. And this is the tube extender, all move. This is only 3-4 millimeter from the limbus. But look here what I found. All the AGV blade over the lateral rectus is not in superior temporal. It is over the lateral rectus. And the surgeon make this is as L shape. See, this is here, the picture. And this is what I found. This is here what I found, the picture here for this. And this is here the situation as I'm seeing. This is here. Look, then the exact mechanism is the AGV blade move from superior temporal to the temporal side. And this is here short inside the eye. Or maybe this was why the surgeon go and make a tube extender. But I think the surgeon here found the AGV blade over the lateral rectus, and this single eye, he didn't need to touch the blade because over the lateral rectus and make this L shape the tube. But why is move anteriorly? I make this animation as expected. This the movement of the lateral rectus make this movement of the tube extender inside the eye. And for that, I decided to cut this movement from the AGV blade to shift to the tube extender, because if the tube and the blade is working very well, I didn't like to remove that, and maybe I have big problem over the lateral rectus. And for that, I fixated the tube. See now, I fixated the tube and the tube extender very well with the Brolin suture. Look here, I tested, is patent working. And here I fixated, go back. This is more 5-7 millimeter back from the original position. And I fixated the blade. Here I found this is there. I didn't need any irregular surface. I made this is more smoothly. And after that, I put this is the tutoblast on fixating very well. Also two layer of tenon and conjunctiva, and close the wound. And this is here was what I had done. This is here fixated with many suture to stop any movement from the AGV blade to the tube extender, and to avoid any more complication in the future. And this is here the picture for the eye. 4 months later, I would be 12 millimeter mercury on timolol. Then see, this is here my first expectation. The second expectation this is the real reason, is the movement for the AGV blast superior temporal to the temporal side. And what I found, this is the current situation. To take home message before that, only I want to see this case. This patient, young girl, come with this uncomfortable from the left eye. When I see anyone sees this is the tube slightly long at the right eye, but the patient comfortable, the tube not touch on the cornea or the lens, but the patient complain from the left eye. When I see, I thought there is a tube extended and touched with the iris and make iris atrophy, or maybe the surgeon trimmed the tube. But before I take the decision, I asked the patient to look to the superior temporal situation and see here. Always the AGV plate move anteriorly or make touch the tube with the iris, and this is make this eye uncomfortable for the patient. For that, please use tube extender in case of retraction of exposure of the tube, but please fix the tube extender and AGV plate very, very well. And thank you and welcome to the Muscat International Conference in combination with the Miyako at the end of November this year. Thank you very much.
Thank you, Dr. Sheikh. It was really a wonderful case, and the way you have beautifully documented it with the schematic diagram made understanding very, very clear.
Yeah, welcome.
What's your experience with the different valves when it comes to silicone oil filled eyes? Would you choose one valve over another?
No, this is when I felt this is anyone felt. I prefer not to touch. Before, I prefer that is to remove, make first if this capsulated to remove the capsule, but unfortunately I found this is totally unacceptable. No result. The capsule will form again. If I want, I will implant another tube. If this is very, very rare, but I didn't prefer to at least to implant a new tube in the same position of the first tube.
If you have to do a tube implant for a patient with silicone oil filled glaucoma, which implant would you
silicone oil? Oh, you mean in silicone oil?
Yeah, an eye with a silicone oil induced glaucoma, where the oil has been removed but the pressures are high. Which implant would you prefer?
This is, in this situation, I will prefer to implant at least inferior temporal position, because superior, at least here in our patient, if the silicone eye removed very, very good, still there is particle of the emulsified silicone oil in the retina on the angle. For that, it's better to implant away from that. Either to implant this is very long inside the anterior chamber, superior temporally, or better to implant inferior temporally.
Right, right. Fair enough. So we will get back to you with the audience questions at the end of this session. And with this, we move on to our next speaker, Dr. Elizabeth Cretera. She is an assistant professor in the Department of Ophthalmology and Visual Sciences at the University of New Mexico Health Sciences Center. We welcome Dr. Elizabeth.
Hello, thank you,
Cretera,
Dr. Perot.
Yeah, welcome.
Thank you. I'm going to share my screen. Are you able to see that?
Yes, visible and audible as well.
Thanks very much. Thank you so much for the opportunity to speak today. I'm going to present an interesting case from our glaucoma clinic. This was a 52-year-old male who had severe primary open-angle glaucoma. He'd undergone a Barrevelt tube shunt in the left eye. He also had a known history of steroid response. He had chronic CME after cataract surgery. He'd already undergone a PPV with a membrane peel, actually in both eyes. Ophthalmic medication at the time of presentation included 4 antihypertensive agents, as well as nonsteroidal and mild steroid. And then the patient also had some interesting complaints at the time of presentation, which included severe physical exhaustion, syncopal episodes, dysphagia, and sinus congestion. For the examination, we could see that the eye pressure in the left eye is elevated to 23. And in the past 2 years after the Barrevelt tube shunt, his pressure had been stable at 8 to 14 range in this eye. It was noted to have facial plethora on exam. And in his slit lamp exam, he had mild chemosis and hyperemia in both eyes. And in the left eye, we could see this Barrevelt position supratemporal, it had a normal blood morphology. And then the tube was noted, the ostium was patent in the anterior chamber. Otherwise, his exam was unchanged from prior exams, just for severe glaucoma. On that same visit, he did a visual field, which was showing worsening progression in the left eye, consistent perhaps with this elevated eye pressure. So question for our audience members, what would you do next? Would you consider discontinuing the fluorometholone drops? Would you do a systemic workup with chest imaging? Would you add notarsidil in the left eye, or would you do another non-valved shunt in the left eye, maybe with a micropulse laser? These were all things that could think about. We're going to make the case that you should do a systemic workup in this patient with chest imaging. And the reason is that we have to keep in mind his other complaints, which are not consistent with the tube failure, which his other choices would have made more sense. We know he's sorry, I'll go back one slide. He has a steroid responder, so you could consider stopping a steroid. Notarsidil could be added to his other classes of medication. And a second tube shunt might be considered if you thought this was a tube failure. But taking in mind his other complaints of syncope, sinus congestion, dysphagia, and then this facial plethora, along with that elevated IOP and chemosis, we should think about a venous obstruction, which is not something that we think about very often. Elevated episcleral venous pressure, we know can elevate the IOP. And so we have to consider that in this case. Just a few words about the EVP. So we remember from the Goldman equation that the intraocular pressures calculated by this equation. So F will be the aqueous production over the C, which is the aqueous outflow, and that is combined with the EVP. So EVP we know is determined by vascular tone and gravity. It is independent of IOP as well as aqueous production. Exam findings that we see in elevated IOP include dilated tortuous episcleral veins, chemosis, and blood in Schlemm's canal. And you can see this picture. This is from the iWiki. Differential diagnosis is pretty broad, so you should think about anything that can cause congestion of those episcleral veins, such as orbital varix, Sturge-Weber as a classic example, direct and indirect carotid cavernous fistula, cavernous sinus syndrome, and superior vena cava syndrome. And then there are also reports of elevated EVP transiently with specific behaviors, such as playing the high resistance wind instrument, wearing a tight necktie, or doing postural inversion, where you invert to gravity. So in this particular patient, his findings kind of more consistent with a superior vena cava syndrome. And superior vena cava syndrome classically will present with the plethora of the face, and this is due to the distension of the jugular vein because of compression of that venous return to the heart at the superior vena cava. As far as the ocular findings, you can have orbital congestion, proptosis, as well as elevated intraocular pressure that is worse with recumbent positioning. The mechanism of elevated intraocular pressure is related to the retrograde congestion from the jugular vein back through the ophthalmic veins and to these episcleral veins. And the differential for this specific cause of elevated EVP will include neoplasm, aortic aneurysm, and then central venous stasis that could be due to indwelling catheters or stents. And so in this patient, he was already talking to his primary care doctor about his complaints, and they were the ones that initiated the CT scan. And this shows in the yellow, you can see is actually a large mediastinal mass, and that is encasing the great vessels of the aortic arch as well as the superior vena cava. And then the white arrow is pointing to the right jugular vein, which appears distended, and then the left jugular vein in blue is actually appears stenotic in this image. And then the inset image down here is actually showing after 6 months after his treatment course of chemotherapy and radiation, and then we can see that reduction in the size of that mediastinal mass. And so, as I already mentioned, the patient had a CT scan showing this large mediastinal mass with stenosis of the left more than right jugular vein. He underwent a cerebroclavicular lymph node biopsy, which was consistent with a diffuse large B-cell lymphoma. The patient underwent chemotherapy and radiation. And after that, his intraocular pressure was better controlled. It returned to that range that it had been after the bare-valved tube shunt. And so I would like to thank my collaborators on this case, as well as our patient who agreed to have his case presented. This case was published if you're interested in referencing it for teaching purposes. But we thought it's a very important case because we have an opportunity not only to save sight, but also to diagnose or help to diagnose a disease that can actually kill the patient as well. Thanks very much for your attention.
Thank you, Dr. Elizabeth. It was really beautifully documented, and it just made us reconsider the fact that we have to go beyond intraocular pressures and findings of the imaging. We are often so obsessed with the pressure, the disc, and the imaging findings that we overlook a lot of systemic features. What's your experience otherwise in patients with Sturge-Weber syndrome, those who have elevated pressure, other than the cause that you just showed to us?
Yeah, so Sturge-Weber is certainly, I think of it with congenital glaucoma or pediatric glaucoma as a common cause of elevated EVP. I don't actually treat too many pediatric cases in my practice right now, but in training, I certainly saw that as a cause. I think it's quite challenging to treat, actually.
Yeah. So I've just had a few patients of Sturge-Weber, and those adolescent patients, they are very refractory to treatment. They might, whatever modality you give to them, that'll work for a year or two. And again, you are presented with a resurgence of the pressure, and it's really difficult to control patients with elevated episcleral venous pressures. So we'll take up the questions at the end of the session, and I would request you to please hang on. And with this, we move to our next speaker, Dr. Ahmed Mustafa, who is the founder and president of the Egyptian Society for Continuous Ophthalmic Education. He is professor of ophthalmology at Cairo University, and he's operating in Libya today and is joining us despite poor connectivity. And I'm really thankful to you for sparing your time despite a busy schedule. So over to you.
Parul.
Hearing from you. Yes.
It's my pleasure. It's my pleasure. Do you hear me, Parul, in the first place? You hear me?
Yes, absolutely. I do.
Yeah, good. So let me share the screen. Okay. Okay, good. So my case today is just navigating a case with the multiple difficulties that we can meet in everyday practice. Just a male, 36 years old with previous glaucoma operation. The vision is 360 and the pressure is 30 on full treatment. The disc is not bad, actually 0.5. And this is the anterior segment imaging. You can see the patient had a valve, and the valve actually is too much in relation to the cornea, causing a lot of troubles and peaking of the pupil. And besides that, the patient is having posterior cortical cataract. And again, the pressure is not controlled. And another problem that the tube is exposed, so that it seems that the patient is having glaucoma and ocular surface problem with exposure of the tube and posterior cortical cataract. The patient is young and is definitely not satisfied with all of those. So I just consulted the patient for what shall we do, and then the rest of the conjunctiva was good, and this was a kind of a gift for these patients that we still have a place for another glaucoma operation. And now this is the operation that I planned with the patient to go through. This is first the inferior corneal traction suture, and now you can see the posterior cortical cataract is very obvious, and this is the quadrant where the valve is. So I'm now working on the other quadrant. Then I injected diluted the mitomycin solution, and the concentration is 0.04 milligram. I injected 0.1 milli. And then I'm planning to go for glaucoma operation in the other quadrant, and then preparing the first flap. Yeah, the eye is a bit congested because of the multiple operations, but again, it wasn't a big problem. Dissection is carried forward to the periphery of the cornea. And actually, my plan here was to do a deep sclerectomy because I think the patient's conjunctiva is healthy and still can benefit from a regular operation. So I prepared the first flap, and then I'm preparing for removal of the cataract. The pupil wasn't enough dilated, and I need to have better visualization. You know, I want to avoid as much as trouble in this patient. So after placing the incisions, I want to go for a kind of assisting this pupil to be more dilated. And I think iris hooks could accomplish this mission, so that I'm placing hooks. This is the second hook, and the view is much better. And then this is the third hook. Then at that time, and I think the valve area is working like the fourth hook, so that I don't need a fourth hook at that time. Cataract wasn't a problem. And then the IOL was placed in the back. Then I'm thinking of relieving the iris tissue that's incarcerated at the site of the tube. Because the pupil is a bit irregular, I want to get more regular pupil. That wasn't possible, actually. So I thought of cutting the pillars of the iris. I want to have a kind of regular pupil, so to minimize the aberrations, you know, that the quality of the vision is important as well, like the visual acuity. So again, I'm able now to repair the pupil and to get a better appearing pupil, actually. And I left some of the residual iris tissue that wasn't possible to remove the whole iris from the surgical site. But again, after placing 2 sutures, I think the pupil is better. And then I'll go back to the deep sclerectomy area to complete the deep sclerectomy, because I believe that this valve, it is not possible to make use of this valve anyway. And then the percolation is good, and the eyes is still filled with helium, so it's okay. And now with the deep sclerectomy, you know, one of the standard operations, the trabecular meshwork started to percolate, and this is the excised D flap. Removal more of the peripheral cornea to give more filtering area. And then afterwards, I tend to place a suture which is published, thanks God, under my name, which is Ahmed Suture, under the scleral flap, with the aim of placing the proximal limb of this suture over the trabecular meshwork in case I want to do goniopuncture and assist my operation. And at the same time, it acts like a spacer, an economical spacer. The knot is buried, and then I'll reposit the superficial flap. And you can see I'm just pointing out that the suture is overlying the trabecular meshwork. The flap here was closed with some sutures because of the filtration. It was too much, actually. And then going back to the third problem, which is the tube here, so that I'm dissecting the conjunctiva around the tube, and I'm quite sure that the valve is not doing anything good. It's only causing some harm to the patient by irritating the eye all the time by the exposed tube. And it might be a conduit for intraocular infection, so that I'm now getting the tube out of the eye and thinking that this will protect the cornea. Again, no more further damage to the cornea as happening here. Removal of the body of the valve would be a big problem, and actually I don't need it, so that I left the body itself of the valve. It would be a hell of operation to go after this, so I left the body, and then I'm closing the defect of the tube by 10-0 nylon sutures, a couple of sutures. You know, usually the opening is a kind of circular one. It needs to be properly closed to avoid filtration through this side. And then after burying the knots, and then I thought, why not to make use of the deep flap of the patient for adding extra support to the surgical side, so that this is the deep sclerectomy flap that was excised from this area. And then I went for removal of the viscoelastic, and the superficial flap was, you know, sutured, that of deep sclerectomy. So that's almost the conclusion. The surgery, deep sclerectomy here, and the flap was transferred to support another area after removal of the valve. And I did a kind of release to the conjunctiva to avoid too much traction, because I'm just leaving the body and I'm covering the cornea as much as possible with the conjunctiva. Now, this is the post-operative picture. The eye is relatively quiet. The pupil, yeah, it's not perfect, but it was, I was satisfied with this. And we can see that this is the old valve area, and this is the new deep sclerectomy area. And actually, the operation, it's here, I'm saying 6 months, it's now even. We're coming to 1 year, and the vision is really good, 6/9, and the pressure is 9. His deep sclerectomy is really working very well. He is on low therapy. He comes every now and then for a check. And this is the valve that I actually left, so it's not working, just surrounded by scarring. And this is the deep sclerectomy area. Again, it's working. So I think in those cases where you have a lot of difficulties, you need to just sit with yourself. You might consult your colleagues to plan ahead, because you are having multiple difficulty how to solve one after the other, instead of managing the patient had like uncontrolled glaucoma, exposed tube, and catheter. So how to navigate between those difficulties? And actually, I was satisfied with the outcome at the end. And thank you very, very much.
You have made the very complicated surgery look so easy. The outcome is just so beautiful, despite all the interventions that you carried out. So it's really important to address and give respect to each tissue as if it was the physiological state of eye. And repairing the iris was equally important as just controlling the intraocular pressures. Any comments from our other esteemed speakers as regards this case? Would you have done anything differently?
You know that Parul, correcting the pupil with a kind of just minimizing the aberration, so that one of my colleagues have said that in this operation, it was just a complicated cataract operation, glaucoma operation, refractive surgery. It's a mix of everything, actually. So that I'm quite sure that the colleagues might have a different plan to come up with something that's new, because the situation is very extraordinary.
Yeah, many times. Yeah, please.
Sorry? Why Dr. Ahmed not remove the tube from beginning on testing the tube, if this is working? Maybe that's the AGV plate already still working, on now only closed with the tissue. For that, maybe can we stay safe if the tube is still working? Can we implant in another place and correct the position, or make extension on the implanted?
Thank you, Ali. You know that the problem that the tube was exposed, so that I have to correct this as well, and I have correct the overlying conjunctiva. Then I have to take the tube to another path, which we could do actually. But I think the problem here that I found that the patient's actually optic nerve was really very good. And I thought, why in the beginning to do a valve for a patient with a kind of healthy optic nerve, and he can benefit from regular operation. But again, the option of getting the tube out and then adding something to lengthen the tube, and then to change the path of the tube, this could be another option, of course. Yes, I totally agree with you that there could be another option. That's why when you plan ahead, you can come up with different ideas that could solve that patient. But again, I was not happy at all with the appearance of the response of the cornea to the implant.
For that, maybe this is for the audience. Plan ahead here is more important. It's not to implant AGV or any tube for this case, because it's still patient faking, young patient, and still the conj is very good.
Yes, yeah, you know that I just kept thinking, why this patient received a complicated valve? Because, you know, he could benefit from something which is less invasive. Yes, I totally agree with you.
Dr. Ahmed, go ahead.
Ahlan, Dr. Bassel. Yasmin, hello. I'm sorry for the...
We have time. Yeah, we still have time for discussion at the end. So Dr. Bassel, please go ahead.
Dr. Ahmed, my question was, in this case, you used the deep sclera, which is cut from the sclerotomy, and you covered the side of the tube. If you don't have this deep sclera, will you use sclera graft patch for covering the side of the tube which you remove it from, or you can cover just with the conjunctiva after suturing the entrance by sutures, the nylon sutures?
Dr. Besser, thank you very much for this nice question. I was satisfied with the closure of the tube with the suture, but at the end of the day, you know that the entry is a bit rounded, so that if I don't have enough sclera, I may think of adding something, but also if I'm satisfied with the closure with the sutures, I would just drag the conjunctiva and cover. But in this case, I was just happy that I have something at my hand which I can make use of it. Yes, yes. Yes,
do we have to move on? I can postpone the question for the end. I wanted to congratulate you, Dr. Ahmed, for a wonderful case, a very challenging case that you managed so beautifully, as usual. My quick question is on the effect of cataract surgery on deep sclerectomy. Is it similar to when we think of combining trabeculectomy, for instance, with phaco, or is it because it doesn't rely on the conjunctiva? You have a lower threshold for operating for cataract, at least in your hands. Do you withhold from combining cataract surgery with non-penetrating glaucoma surgery, as you probably do for combining it with trabs?
So let me just rephrase the question to make sure that I understand this carefully. That you are asking about combining phaco with the deep sclerectomy as
yes.
the one
Do you think
operation?
It has some adverse effect on the IOP control, like it does for trabeculectomy when combined with phaco?
You know that actually, when you combine both, you don't know how much the magnitude of IOP reduction by the cataract itself. So the combination is always beneficial. And might be some few patients could use like one medication, but actually it is just from my observation, combining phaco deep sclerectomy in open angle glaucoma is actually, for me, it's a much better option than combining with trabeculectomy, because I have seen that trabeculectomies, they usually do scar, but I think the results are better, at least in my hands, when I combine phaco deep sclerectomy.
Right.
But another point is, you know, that there is an incidence of, you know, the complication when you go just for trap. I think like 40% will develop cataract like in a couple of years, so that the incidence of cataract is high. I don't see this incidence is the same in deep sclerectomy, which gives another advantage for this surgery.
Very good point. Thank you.
Thank you so very much. And in the interest of time, we move on to our next speaker, Dr. Basil Al-Fawri. Dr. Al-Fawri is a renowned international surgeon with interest both in adult and pediatric glaucoma, and he's currently working in Al Garhoud Hospital in Dubai and also operates in Sharjah. So over to you, Dr. Fawri.
Thank you very much. I will share my screen. Okay, indeed, I will go quickly with my presentation. First of all, thank you very much for the invitation for this session. Indeed, I will share with you this case. One patient, 43 years old, male, Asian, referred to me with a complaint of left eye pain with blurry vision. Started 1 week ago. This patient treated by one of my colleagues with maximum medications, but the pressure is still high in his left eye, and so he referred him to me for surgery indeed. So when I examined the patient, I found the left eye vision 0.7 with the cornea mild edema, pupil mid-dilated with poor reaction. The pressure was 43 in the left eye with full anti-glaucoma medication. The right eye was normal in pressure and in vision. When I examined the patient carefully, I noticed that yes, this eye pressure is so high, pupil dilated, pure reacted. But on slit lamp examination, I noted that the anterior chamber deep in the center, but in the periphery, as seen here, it's shallow. It's notable that it's not usual to see a shallow anterior chamber in the periphery with deep anterior chamber in the center. So this raised a mark for me that the diagnosis should be put carefully before going for the surgery. So I did a gonioscopy for the patient and I found the angle closed, but it's a positional. Yani when I apply indentation, the angle opened a little bit. So all my plan changed from surgery to another thing, because in this case, as seen here in the OCT also, the right eye and the left eye have the same criteria. I mean, narrow angle, a positional angle in both eyes. So I here put the diagnosis as a plateau iris, and we have, just to go a quick review over plateau iris. It's often seen in young patients, okay, equally between men and women. It was relatively common, 6 to 20% of eyes with angle closure. This can occur spontaneously or after after dilation by medication. If not diagnosed and treated properly, a pass can happen and closure angle, permanent closure angle can happen. We have to pay attention to differentiate between plateau iris configuration and the plateau iris syndrome. So just to put in mind that to say this case is a plateau iris syndrome, after putting the plateau iris configuration, deep anterior chamber and narrow angle, we have to do a peripheral iridotomy. If the angle is still closed and the pressure is still high, that means it's now a plateau iris syndrome. So that's what I did for the patient first. I did a laser peripheral iridotomy, but it is the patient peripheral iridotomy by OCT, anterior segment OCT, but the pressure still high. So what I have to do later, 2 days after peripheral iridotomy, the pressure is still 31 with maximum medication. So I did for the patient iridoplasty. I did it for both eyes. I prepared the patient with pilocarpine, 1 to 2%. Then with iridotomy contact lens, I applied with 500 micron spot size, power 200 millijoule and the duration 0.5 second. And after the procedure, I put the patient on primidine immediately and steroid for 5 days. Days post the procedure, now the pressure become normal. It's 11 in the right eye, 13 in the left eye, but with exolamol. And the cornea became clear, the anterior chamber deep in the center, and become more deeper in the periphery. And here we can see the photos of the patient after iridoplasty. We can see here the scars of the argon laser in the periphery of the iris for the left eye. This is the eye before the iridoplasty in the right and after the iridoplasty in the left. We can see the change of the size of the pupil before and after. And here by OCT, the angle of the left eye in the nasal side and temporal side. And here is the angle after the iridoplasty. It's much, much better. Here we can compare the angle of the left eye before iridoplasty and after iridoplasty. And the same, which we can see for the right eye before and after iridoplasty. The angle much, much better. So in this case, we can say that the proper diagnosis will help us to choose the proper treatment for the patient. And instead of doing surgery for this patient to control the pressure, by iridoplasty, argon laser iridoplasty, we overcome the attack of the eye, the high eye pressure, and to put the patient in the safe side. And at the end, we can see if something isn't working, don't try harder or do more, do something different. Thank you very much for your attention.
Thank you so much, Dr. Alpauri. And without much ado, we'll go on to our next speaker because we are running short of time. Last but not the least, we have the very wonderful Dr. Vanitha Pathak. She is a surgeon who is practicing in the southern part of India and Center for Sight, Hyderabad. Her forte is not just mixed, but otherwise refractory glaucoma surgeries. And over to you, Dr. Pathak. Thank you for joining us today.
Thank you very much. Dr. Basil, can you unshare your slides, please? Thank you. Thank you, Parul, and thank you, Dr. Amrit, for this invitation once again. It was wonderful being part of the same meeting a couple of years ago. Today I'm going to talk about, narrow angles, shallow AC, and my job has been made very easy by Dr. Basil. I'm going to talk about a patient who presented to me a while ago, just after the first wave of COVID. I don't have any relevant financial disclosure. So this is a 56-year-old female who was complaining of left-sided headache and blurred vision for 4 months. In her past history, she's already had a laser peripheral iridotomy 22 years ago. And following that, I don't know, someone guided her to have LASIK for hypermetropia, and this was done 11 years ago. And at that time, the CCT was recorded as 480. Before she was referred to me, an LPI, laser peripheral iridotomy, was done once again. She didn't have any significant systemic, family, or ocular history. She wasn't on any medication at the time she came to me. So when she came to me, she did have 20/20 vision, but as you can see with the hypermetropic correction, and she had 3 patent PIs. AC was extremely shallow, and a pupil, though not on pilocarpine, were very, very small, almost like senile meiosis, although she hadn't reached that stage yet. And both eyes, she had very early cataract, and her pressures were 20 and 18. As you can see, there are 3 PIs on both sides that were patent, but extremely, extremely shallow AC. And of course, on gonioscopy, when I did it, it was a post PI occludable in both eyes. I wasn't sure whether any pus were present because the indentation was quite difficult, and undilated disc examination was more or less normal. I did want to move on to a UBM, also wanted to do an ASOCT in biometry, but unfortunately, she didn't want it on the same day. And when she did come back, she was complaining of pain during the UBM itself, which had to then be abandoned after the axial scans, and her IOP at that moment was recorded as 39 and 17. She was given pilocarpine stat, and 2 hours later, her pressure came down in the right eye. So this is her UBM. Not the best, sorry, but you can see features of plateau iris syndrome. You can see that the ciliary bodies are all anteriorly placed, as well as no iridociliary sulcus. And you, together with it, you can see that there's very significant lens vault in both eyes. Biometry, very small eyes, very shallow AC, as we all saw clinically too, and lens thickness 5 millimeters at her age, and significant lens vault. I'd like to do lens vault measurements on ASOCT. Unfortunately, I had to do it on the UBM itself. So of course she is a post LPI occludable, and she has both plateau iris syndrome as well as increased lens vault, contributing to her angle closure. So in view of the recurrent angle closure A sequential cataract extraction was recommended. She was counseled for a argon laser peripheral aeroplasty as well, but because she's had 3 lasers in the past, she decided that lasers are not going to help her anymore. Anyway, so she was advised in the interim before she underwent surgery, pilocarpine to be discontinued a day before surgery. And when surgery was planned, no pre-op dilatation, we discussed that we will do it on the table, and a pre-op mannitol was also given. Of course, given that she had LASIK, there were lots of issues with IOL calculation, which is beyond the remit of this particular talk. On the day of surgery, again, she complained of right-sided headache of 6 hours duration, and her IOP was recorded as 32 and 17. So she was given mannitol once again, and pressures of obviously preoperatively were measured under adequate antibiotic prophylaxis. On the table, she was dilated with intracameral, what we call phenocane plus, but basically this is a concoction of lidocaine as well as tropicamide and phenylephrine. And intraop mannitol had to be repeated as AC was still shallow and was not not deepening even after cataract was removed and IOL was placed. And even with sodium hyaluronate, it wasn't deep. So with a recent, very recent, and I've published this, management of a patient post cataract surgery with aqueous misdirection, I approached this patient in the following way. So here we are. This is a brief surgery of that patient. She wasn't dilated prior. Phenocane is being used here. You can see it instantaneously dilated. A very careful rhexis was done because of increased lens vault. You can always run out. And a little bit smaller than what one would like, but that was acceptable. Think, when phaco was started, you can see very, very thick layer of cortex, but other than that, it was absolutely uneventful. However, the AC remained shallow, even with sodium hyaluronate injection. So mannitol was repeated intraoperatively, and it still did not deepen the AC. So after placement of the IOL in the bag, what I did was use an anterior vitrector to enlarge a pre-existing peripheral iridotomy, and then used an MVR blade for a vertical entry, just overlying it, inserted a vitrector vertically down to do zoniolectomy, and then turned the vitrector to face anteriorly to do a complete anterior hyaloidovitrectomy, all within anterior vitrector. And I like to do a primary posterior capsulectomy because that tells me that the anterior hyaloidectomy is complete. And then after that, she formed even with an air bubble. So this actually is a schematic of the same that I did. I enlarged her PI. I went through her through a corneal incision. I inserted a vitrector. Anteriorly, and then come up right up to the lens and do a primary posterior capsulectomy. And you can see a postoperative picture of that primary posterior capsulectomy. This I have done now through various incisions, corneal, ostial, pars plana, and I have reported it. This is actually a very satisfying procedure that helps to resolve aqueous misdirection, should it happen either intraoperatively or postoperatively. So she did very well postoperatively. I don't need to go through it, but you can see how deep she became, and you can see her primary posterior capsulectomy as through the retroelimination. Left eye surgery was still pending at the time. Believe it or not, she had recurrent attacks in that eye too, severe headaches 4 days prior to. the scheduled surgery. She was given intensive pilocarpine and controlled with oral carbonic anhydrase inhibitor. She was still 26. She underwent a very similar surgery on day 1. Here she did slightly better. As you can see, deep AC, and you can see her primary posterior capsulectomy in the left eye as well. And just as a reminder, you can see how shallow she was before. So now I have a follow-up of more than 2.5 years. She is best corrected 6.6 N6 with a very deep AC, controlled IOP. And just to summarize, I'd like to tell you that this was a case of plateau iris syndrome with increased lens Walton. All this diagnosed post PI. She was getting recurrent acute attacks, and therefore she underwent both eyes lens extraction with iridozonulo-hyaloidovitrectomy, along with a primary posterior capsulectomy. She had unaided 20/30 N8 vision, which I think was way better than what her LASIK managed to achieve. Nonetheless, what was most important to me was that she had deep AC and controlled IOP after surgery. So the key points here is that every patient who is undergoing YAG-PI really needs a post-LPI gonioscopy. Once relative pupillary block element is eliminated, doing another LPI really does not help. And under these circumstances, UBM is the investigation of choice. And you can use pilocarpine because that is what breaks the attack. So the double trouble that I had in this shallow AC was not only the recurrent attacks, acute attacks that I was getting, but also the fact that she had developed aqueous misdirection intraoperatively. Of course, appropriate measures should be taken based on experience and confidence. And in my personal opinion, LASIK should be avoided in these kind of glaucomatosis. Thank you very much for patient listening.
Thank you, Dr. Vanita, and thank you very much for such enlightening cases and a wide variety of cases. In the interest of time, we will not be able to take any questions because the next session is awaiting and it's in the same hall. I would also like to thank my co-moderator, Dr. Yasmin Al-Said. She is a professor at the Cairo University, and due to some technical glitch, I couldn't introduce her earlier as her video wasn't streaming. Thank you, everyone. Thank you, Dr. Elizabeth. Thank you, Dr. Basel, and for sparing your time and joining us today evening. Thank you, Dr. Ali Al-Sheikh. Thank you. Have a wonderful day.
Pleasure. Thank you very, very much. See you. Have a great day. Thank you. Bye-bye.
Thank you very much. Thank you very much.
Bye.